Hello, welcome to What the Flip podcast. I'm your host, Victor Vogel. Once again, we're here on this evening, and we're going to cover our fourth in the series on healthcare and the cost of healthcare, and learning a lot about what makes our healthcare system tick, or probably more to the point, what doesn't help our healthcare system tick well. Uh, Boy, do we ever need this more than any other time that's out there. So, once again, this will be available along with the three previous sessions we've done on the Facebook page that's streaming across the bottom there, What the Flip Podcast. If you go there and you can like the page or not, but if you go to that page, go to the video section, and there will be a series. There's 3 episodes in there already, and we'll be doing an episode underneath that. That will be number 4, which I'll probably post sometime tomorrow in case you didn't see this. When we're doing live broadcasts. We are doing a live broadcast, and so you have an opportunity to put some comments in there, and when the comments do appear, I'm able to kind of show those to folks, in the process. Along the way, if somebody posts a comment, then we'll pop it up. It'll look a little like that. But I'll try to keep a look at those. It's kind of hard to do those while I'm actually streaming because I'm doing this as a one-person show. But I'll try to take a second in the middle of all this to take a look to see if there's any comments or questions that people are posting who are actually looking at this live right now on Facebook. Let's go ahead and get started with what we're talking about tonight. And what we're talking about, let me just kind of take this streaming sign off of it so we don't get distracted. We're really talking a little bit about finding out. We talked about how much money we were spending. We talked about how expending all that money, how much or how well we compared to other similar countries that were democratic and also had a bent towards free economy, so to speak, and had a healthcare system in place. We're nearly all of these other countries are basically government, single payer, government paid supported programs. We are about the only country on earth right now that has the system we have, which is privatized system, privatized healthcare, so to speak, where you and your employer, for example, pay for a large portion. We found that out. A large portion is paid for by the public compared to other countries who, when you compare the United States public contribution to the rest of those countries, we were pretty even with those countries. But then what shot our expense up is where we charge all of us, or not me, I'm on Medicare now, but when I wasn't, I got charged the same as you did, and that shot our expense up way over any other country. We also looked to see how much of that was contributing, and we found out that, our morbidity rate from the point of birth to the time we die is actually less than other countries, and that's not good. And of course, there was in terms of childbirth, death, childbirth, we rank pretty low against the rest of the countries too. So those are things that are going on right now. Then we took a look and we said, okay, what categories do we find spending in Monday's session? And we found out a lot of this spending is in the area of hospitals and the cost of hospitals and managing hospitals, and that whole concept. We're going to discuss some of that more in upcoming sessions about how that's happening and the impact it's having on like rural communities and things like that, and cost. And so the service of hospitals, and then the other side was professional services, which that plus hospitals accounted for something like almost 55 or 60% of the overall healthcare costs, which is interesting because everybody keeps pounding on this. We got to lower drug costs. The reality is we found out last night drug costs in terms of cost against the whole healthcare system is only about 9% of what we spend out there, according to the Brookings Institute, which is this study or this blog I'm reading or article I'm reading and actually quoting. And I will give this to you at towards the end of the series. I'm going to go ahead and give you all the links to that and other books and stuff I may mention in the process of going through these, so that you have all the resources and references to look up to while you're looking at the sessions. But I want you to kind of pay attention as we go through these. And then I was hoping maybe people would join me. I know it's short notice, but people would tell other people and people would join me and maybe post some questions so we could get some dialogue about answering some of these issues. But tonight we're really talking about, okay, out of those categories, relative to the use of those services, whether it's hospitals or professional services or long-term care or nursing homes or pharmaceutical drugs. There's groups of people who consume those that constitute the spending on our healthcare costs. And so we're going to cover that tonight. And hopefully we'll give you a chance to see a little bit about where all of this money is by whom all this money is being spent. And particularly remember, since a large portion of it is the private industries paying, that's where we far exceed everybody else. So that means you out there who have a private healthcare plan that are paying these kinds of services. So let me begin by saying the half of the population using the least healthcare accounts for only about 3% total, not just out of pocket, but total expenditures, excluding long-term care and hospice and things like that, and some other components of spending. But that's half of the population using the least health care accounts for only 3% of the people who tend to use health care at all. That's a small percentage of people. Half of the population account for only 3% of the spending of all of healthcare. Out of all those services we talked about, only half of the population accounts for only 3% of all of that spending. So 97% got to come from somewhere else, So that's something to keep in mind. And so one of the reasons for this is that healthcare misfortunes they're really random. Like when I was about 2 years ago, this coming January, I used to always throw on my backpack and I'd do a 4-mile jaunt, 2 miles down to the grocery store, 2 miles back with my backpack filled with groceries. That was my exercise. And one time it was snowing like crazy, and it had stopped, and I thought, well, I think I can make it down there and I can make it back. I'm just fixed on getting my exercise in. Well, on the way back, I slipped on ice, and just freakish accident. I was being very careful, but hit the wrong spot at the wrong time. My feet went out from under me, hit the sidewalk, broke my left femur right at where it connects to the hip, required a whole hip replacement. The last thing I was thinking about when I went to the grocery store and on the way back. Okay, when that happened. So these things happen randomly. You never know when they're going to happen. A car wreck, you get sick with something that is unique, or who would have ever thought about a pandemic? Okay, so there you go. So that's one reason why it's hard to calculate who is responsible for the major spending, because even though you're younger and maybe you're part of that group that's only spending 3%. If you have an accident like I just told you, you just all of a sudden spent $75,000 in healthcare expenses. Okay, and so that's the dilemma we struggle with. Is healthcare is not something that's extremely predictable. So that's something to keep in mind. In any given year, the distribution can be very unequal, but only some of those with the highest spending will continue to have high spending in subsequent years. So we mentioned a couple of slides back, a chart. So let me go get that chart and put it on the screen here for us. Let me see here. There we go. So really what this chart is doing is this chart is showing you the distribution of healthcare expenditures for the population. And if you look at the top, there's on the left-hand side, there's a very thin line of dark orange. And that then correlates to the right. There's a pop out on the right of each one of those percentiles that says 22% of the expenditures mean spending is $116,330. So these are now the people who fall in the top 99 to 100 percentile of those actually spending the money in the healthcare system. So again, if you look down at the bottom, what's below the bottom 15 percentile, or actually let's go to the 5th to the 75th percentile, which is an extremely large spread of people. They account for only about 3% of those expenditures. So that light green area is what we were talking about just a minute ago. Those are the people who don't expend a whole lot of money on healthcare. And they literally only constitute 3% of the whole spending. If you go between the 75th and the 90th percentile, you find that these people are 21% of the expenditures, and their mean spending, and this would be kind of like on an annual basis, is about $7,000 a year on healthcare expenses. And so, and then it goes up from there. Between the 75th or between the 90th and the 95th percentile, 28% of the expenditures mean spending is $37,000 a year. These are people that have ongoing expenditures in the process. And as you might suspect, these are people who are in the older population. So as this says here, in any given year, the distribution can be very unequal, but only some of those with the highest spending will continue to have high spending in subsequent years. They start where they maybe have an issue that's diagnosed, and then it becomes chronic and ongoing. Now, why is that important? It's important because there was a case in the Supreme Court to eliminate the ACA, and when they did that, they would eliminate pre-existing conditions. So if you happen to be employed with somebody and you were diagnosed with diabetes, and then you lost your job with that company, or you switched, or you had to relocate and you took another job, you fell under their health care plan. Prior to that ACA and that pre-existing clause exclusion, they could look at your insurance and say, and then all of a sudden it says, oh yeah, your diabetes accelerated and it's now affecting your kidneys and you need to go on dialysis. Well, they could look at that in the past and say, well, you had a pre-existing condition, so we're not going to pay for the dialysis. And you were stuck with the bill. And we're talking about a significant bill. So that's the kind of things that are happening to people in that 75th to 90 percentile on up that have an ongoing condition. If that happens to you when you're younger, it tends to happen to you when you're older. But if it happens to you while you're younger, then you would find yourself in very, very difficult ongoing times. And right now, insurance companies cannot prohibit you from doing that. They cannot prohibit you. They can prohibit companies from saying, hey, you can't have this insurance covered because it was a pre-existing condition. So that's something for you to kind of keep in mind. The bottom half of the healthcare users are disproportionately young and consequently less likely to need expensive healthcare. But they might, apt to need it later in life. So this is something you need to consider. It's not something you should just be thinking about right now. You need to be thinking 15, 20 years out. What's going to be there for me then? Like Medicare is here for us now. If we eliminated Medicare and I had to pay that $75,000, I couldn't have paid the $75,000 for my hip. So what would have happened? Do I just walk around with a busted hip and they just simply pump morphine into me all the time? Or do they fix that and then they write, then I have to have my check garnered and I have to pay $20 a week for the rest of my life, which may not be very long for them? Or can they write that off? All of those things are things that are talked about in the private healthcare segment because it's operating kind of like a capitalistic society. In other words, we're having to go out. If your car breaks down, you have to pay for your car to get it fixed. If you break down, you have to pay to get yourself fixed under private health insurance. That's why you buy the insurance as a protection to reduce some of that. But over the years, that's become more and more expensive, both in premiums and deductibles. In order to keep those premiums lower, it's gone higher. So your out-of-pocket expense up front all of a sudden gets to be a lot more. Sometimes if you get into these categories like the $37,000 a year or up to the 22nd or up into the 95th percentile bracket up, where you're talking about anywhere from $116,000 a year up, all of a sudden, you just don't have that money. People the vast majority of the population just does not have that money available to them. So in any given year, that distribution is unequal, and it's like disproportionately that the younger people are in fact paying, or spending a lot less on healthcare than the older people who are paying for health care in the system. And that's something that is impacting people quite a bit. So many people are going to incur high end of life expenditures, such as cost accounted for, those people accounted for about 13% of the personal health care costs back in 2011 when the study was looking at literature and data associated with that. And sometimes you can't find that data much past that, but even back then it was 13% of personal health care costs were in those high-end lifetime expenditures up in that 90th to 100 percentile bracket. So, but in any given year, most people do not incur those costs. Also, at 13%, end of life care is important, but it's really not a dominant part of the U.S. healthcare cost. So if you're talking about how many people are in that category and compare it against the overall cost being spent, that 13% of people really aren't representing the vast majority of our healthcare cost, even at that age and even at that perpetuating healthcare situation. So that's something for you to keep in mind. Just because there's people that are older and their healthcare is costing more, and there are people younger and they're virtually spending nothing, the overall healthcare cost structure, that spending, this cost of spending, is not necessarily found in how much these people are paying out. It's more in how the hospitals are run, how the professional services are billed, and things like that. How it's structured. If it was structured different, this 13% would pay a lot less going into the system, but they can't. They just don't have the option of changing, because it's like, I can't go out and shop like I do for a car and say, oh, I've decided I don't want to go to this hospital. I want to go, because these things don't happen like that. Have a heart attack. You don't sit there and say to the first responder, now hang on just a second, is there an ambulance service that is less costly that could come take me? Oh, by the way, I'd like you to give me a list of the 4 or 5 hospitals in the vicinity and what they charge for admittance and x-rays, and what is the billing on. You just don't do that. You have a heart attack, you go to the hospital and you get taken care of. So there's no negotiation here, folks. That's part of the problem with putting the healthcare system into a capitalistic environment. It's unpredictable, it's random, and then put on top of that hospitals are not just operating to keep you healthy, they're also operating to make money. People are trying to be a capitalist. They're trying to make money on healthcare. That's why they're in the business, whether it's pharmaceutical, whether it's professional services, whether it's hospital, whether it's nursing homes, long-term care services. They're trying to make money. So that's something you need to be aware of. Okay, so when individuals incur high costs, insurance is usually necessary to prevent extreme financial hardships, and that's what people are trying to do. They're trying to buy insurance to cover these. The top 1% have mean healthcare expenditures of over $100,000, and the next 4% have an average of $37,000 expense, and that's well over beyond what most families can pay for. So you're almost required to have this insurance, even as they increase the cost of that and increase that deductible for you to pay, which also many people can't afford out there. The average, we're not talking, when people think, well, you got health care, you don't necessarily, you got to remember, people go into severe debt with health insurance. There's a tremendous amount of bankruptcies with private health insurances in this country right now. Okay, at the same time, the experience of insurance means that patients bear less financial responsibility for the cost of their care. And consequently, in some cases, they have less incentive to control the cost. Did I really need that test that you said I needed, Doc? Is that really important? Do I have an option to say no to that test? And sometimes doctors and hospitals will run these tests up just to ensure, that we drag in a little more money. And as that becomes more conglomerate oriented, you'll find that's the case also. In other cases, such as emergencies, patients are often, like mine was, unable to compare costs. I mentioned earlier I had an out-of-network doctor working in an in-network hospital that sent me a $1,500 bill for the 5 or 8 minutes she spent with me, kind of talking to me and saying, oh, yeah, it sounds like your hips broke. Well, that's what the first responders told me that. But I got charged $1,500 for that 5 or 8 minutes. That got negotiated down to $400, which Medicare paid all of it. Okay, so why was the $1,500 charged in the first place? I mean, what is that? $1,500 for an 8-minute discussion? And then they took $400. Why did they take it? Because they were going to get no money from me if they, likelihood I was going to default on the $1,500, and hurts my credit, but I'm $1,500 richer. She's out that money, so she takes what she knows she can get, which is about $450. Don't feel sorry. $450 for an 8-minute conversation times maybe 10 patients into the emergency room, multiply that out. That is Mercedes and large home money. Okay, so these doctors are not going to go anywhere else if they go under a single payer healthcare system or Medicare for all. They're not going to lose their homes. They're not going to lose they're going to make lots and lots of money still. There's no question about that. They may not make what they think they want, but they're going to get a reasonable price. They're going to make a good living at it. And if there is no other choice, sure, they could leave the country and go work somewhere else, but all other countries don't have what we have. That's why they're here. So they wouldn't go to other countries because they may not make as much as they would here in our country under our Medicare program. So see, that's how this is working. They threaten you, we're going to lose all our doctors. No doctors will sign. Well, hell, if you paid a lot of money to go to school, you're probably not going to give that up real easily. So don't worry about it. But that's kind of the things that's going on relative to these paying. Now, keep in mind, a large portion of the population won't reach that until they get older. And those that are older now, they're the biggest spenders and the least likely to be able to afford to pay for it because they're probably on Social Security and Medicare. Okay, so both of these features mean that normal downward pressures on prices may not operate in the standard way in a healthcare market that they would in, say, a private capital market, like buying cars or competing for retail items in a store, or comparing computers and things like that. So the next time we're going to be actually delving into the impact of this 90th, percentile bracket. How is that happening, and how is that affecting us? Things like you take what we've discussed so far, where let's just take hospitals. Hospitals have organized into conglomerate societies. Doctors have moved to more specializes versus general practitioners. They, in turn, have moved to more populous areas for marketing reasons. That's where they get the most population that will pay the most money for hospital services and specialized doctor services. Well, what happens means all of that then is not available to the rural communities out there. It's like I live in Brighton, Michigan. That's a rural community in Michigan. We have great hospitals here. I can attest to that. But they belong to a conglomerate. And you try to get a doctor around here to send you to someplace that costs less money for a test versus having to go to the hospital and spend 3 times much money because they're affiliated with the hospital. Okay, and it's not the doctor's problem. They're forced into that revenue because if they didn't go that direction, they would not have the referral services necessary to sustain their business as a doctor. So this is what's happening. This is what's going on out in our medical community. And this is what we're going to need to consider when we're talking about, what do we want to look at from a healthcare standpoint in the future. I'm telling you, it's just not a situation that's real simple to understand. More importantly, I don't think it's a situation where people really can consider it in a capitalistic world, private industrialized world. So I've come to the conclusion as I'm reading through this, there's probably other things too that are best not put under a competitive capital environment. So instead of trying to put insurance out there and say, oh, we're going to make it competitive, we've already seen it doesn't work because there's only like 3 or 4 major insurance companies. There isn't 300 of them out there. All of those little insurance things you get in the mail and on the phone that say, call us, write us, we'll give you the best quotes. They're actually quoting for these big 4 or 5 big insurance companies. So they're not insurance companies, they're brokers. They're brokers for the in between. So these are things that you need to be aware of and understand that's going on right now that are driving that cost, that privatized cost. And somewhere down the line, towards the end, I hope to get 2 or 3 people who have private insurance on this program live with me and to talk about how much it costs them annually or month by month, equaling annually, how much they pay for their insurance, what they get for that, and then put my Medicare on the table, how much I pay for my Medicare and what I get for that. You're going to see our insurances are comparable. I've already done this with a lot of people, but it'd be nice to get it, recorded, so to speak. We have comparable coverage. If not, and Medicare might be better. What makes the difference is Medicare does a fantastic job of negotiating the price down. The cost goes down considerably. In fact, they're so good at it that the private industries have contacted the Medicare group to help them understand how to negotiate the prices down for their services. So why? What is the purpose? Why is your private insurance? If we have comparable insurance, we put it on the table and look at it. It's comparable. And maybe mine's a little better in a lot of cases because my deductible isn't as high. And if we operated from what some people are proposing in a Medicare for All program, you wouldn't have a deductible. There's just no deductible. There's no out-of-pocket expense. So take that. Your coverage is good. There's, maybe you might find a doctor out there. If all the doctors had to take Medicare, period, if they didn't have a license, if they have Medicare, if they had to take it, if they didn't, and if they did take it, they were guaranteed an income, so to speak. They didn't have to do all the billing. They didn't have to handle all that mess. All they had to do is submit the invoices. Why? Why is it people are so hot about their private insurance? Why? It costs you more. You have out-of-pocket expenses. You've got, the deductibles. You've got all kinds of things that you really don't necessarily deal with in Medicare. When if you just show your Medicare card, boom, you're gone. Now, if you think that your supplemental plan on Medicare is in fact the one that's providing you all these services, you're wrong. You're dead wrong. You start looking into who negotiates down the prices. You're going to find really these major groups like Humana and Blue Cross Blue Shield and United, the biggie, all these guys are doing, they're pass-throughs for Medicare. Medicare has the plan. They negotiate down the prices. They pay the major percentage. Whatever small percentage that insurance company makes up, most of the time they encourage you to get in and get out of there so they don't have to pay that you're covered under Medicare. For like my hip surgery, I went on a Thursday night. Friday morning, I had surgery. Saturday morning, I was walking. I was out Saturday evening. I was covered 100% under Medicare. So my supplemental didn't pay anything for my hospital beds and stuff. That was all Medicare. Now, what happens is they handle all of the processing, though, for Medicare. And then they take a percentage for doing that. Okay, so this is what's going on in your healthcare system if you're on Medicare. So it's kind of like when I sit down with somebody, I say, why are you paying thousands of dollars a year if somebody's offering you the opportunity, if you can get people to vote on this and vote it through, the average citizen, 75% of the people out there making not very much, less than $100,000 a year would not have health care costs. And if Joe Biden is true to his word, you also wouldn't see increases in your payroll taxes, okay? Because you're not going to get taxed. It's going to be the other people. They don't like it. The insurance companies don't like it for sure because that's going to impact executive bonuses. And hospitals and them, they're not liking it because they now are not getting to negotiate all of those things where they say, hey, you doc, you got to come in here and use this service I have in the hospital for lab testing versus the one out here charges a lot less. Okay, all of that starts balancing out and people go, aha. So there you go. So these are the kinds of things I'm trying to help people understand. Because when you read some of this stuff, you get started into it and you go, I don't want it. I'm done with it. I'll just let it go like it is. I mean, I guess I'm making it. Well, you're making it until you are in that 75th percentile where your expenses are going to exponentially grow. Then you're stuck financially. Then all that you work for to retire on gets eaten up in one event. Wouldn't happen under a Medicare plan. So, if you're between 55 and 65 and you're overweight and you're not healthy in America, which is another problem we have that adds to the overall cost, generally it's private cost, and something happens to you, like a heart attack or something severe like that, it's going to be an ongoing expense from you from that point on. And you're still on private insurance, you're going to get eaten alive financially. It's just that simple. Money that you wouldn't have to put out if you would have been on Medicare at that age. It's just that simple. Now, so if you can come in here and argue me out of that position, if you can show me something where that would not be the case, if we had a Medicare for all, I would love it. But you can't just come in and say, I think you're going to tax me anyway. Okay. And even if I taxed you some, I'm thinking you're probably going to pay with those taxes, you could pay a hell of a lot less with a lot less headaches than you would if you kept your private insurance. It's kind of fascinating. It's kind of fascinating we're going there. So anyway, that's what we're going to do. We're going to take a look next week at, these upper brackets. We're going to talk about those, and maybe I've talked about them a little bit right now. And then we're going to get back and down into the meat of this hospitalization and professional services, how those things operate. Do you really know how your doctor operates with the hospitals that he's assigned to or not? Why do some doctors assign it? Why would not all hospitals take all patients from all doctors? Why do they have to go to St. Joseph? Or why do they have to go to Ford Center? Why do they have to go? What is it that drives doctors to take people there? If you think it's one of those scenarios where we think St. Joseph may not give the same quality service as Ford, I think that's probably a wrong thought process. They're both really good hospitals. My guess is you're going to get comparable service. Okay, maybe some of them, Walter Reed, or maybe the Cleveland Center specialize in Houston, they specialize in cancer. Cleveland Center specializes in heart disease. And maybe if you have a situation like that, you've got to make that decision. But generally speaking, across the board service-wise, hospitals do a pretty good job. Doctors, nurses, they all do. They're forced to making choices. Doctors are forced to make choices in that arena. Okay, and we'll talk about other things like that. So stay tuned, because there's some more stuff coming. The more stuff you're going to hear, I think the more interesting it's going to be for you when you start making selections about what you want to do with insurance, which you're having to do right now. But unfortunately, you're having to make those decisions now, and then you have a president that's coming in who may put in a plan that alters a whole lot of stuff if we can get a Democratic Congress who may in fact, Senate, who may in fact vote in a health care plan that people can opt into that is very much like I've been discussing, maybe not totally 100% right, but very much like I've been discussing. You're going to see a lot of people looking at that going, now wait a minute, this makes a lot of sense for me to be in here versus pay private insurance. And if you're wondering whether the government controlling my business, the government's Medicare program is 10 times more efficient and effective than private health care right now. Otherwise, private health care wouldn't be coming to us and saying, help us figure out how to bring the cost down. There you go. There you go. And I'm telling you, if it's a matter of selecting, quote, a doctor I want, there are a lot of doctors out there that you can look at that are really good doctors. I've learned that because I've moved all over the country. So I haven't had the same doctor forever. And I haven't seen that much difference between doctors providing me service. Some of them have better bedside manner, but that's a matter of sitting down with him and saying, "Hey, doc, I need you to be more sensitive to me, or I'm going to go across the street and find somebody that is." There is somebody out there that is more sensitive. So that's part of it. You have to manage that. You'll see that happen. Well, now that we've done all that, I'm going to go have my glass of wine and get ready to talk to you about some more stuff coming up Monday and Wednesday of next week. And keep an eye on this Facebook page, because I may slip in a couple of more of these a week to get all 12 of these facts out fairly quickly now, because I think it's important we understand this as you go into this decision about healthcare and other things like that. While you're out there negotiating with your insurance company, ask them about things like, by the way, how do you negotiate your prices down with doctors? By the way, how does a doctor set their price, and what is it what role do you play in setting that price? And, tell me the difference between these. You're going to find yourself stonewalled. I mean, I was stonewalled for 6 months trying to figure this out. It's because they don't want you to know, folks. They don't want you to know what's going on. And that's not a conspiracy. It's just kind of protecting a good old boy system that's been going on in healthcare for so many years now, that is making a lot of money for a few people and costing a lot of people a lot of money. Okay? You have a great day. Again, wear your mask. I've done a lot of podcasts on What the Flip about starting back in Memorial Day, saying if you don't wear a mask, if you don't social distance, you're going to be in a lockdown. Guess what? Memorial Day, it happened. We restricted again. 4th of July, we restricted again. Labor Day, we restricted again. We put kids in school. We took them out of school. Now, here we are again. People are just ignoring the reality of things. And here we are going into another lockdown. And it's going to be all over the country. And for those governors who refuse to do that, we really all hold them accountable for the deaths that they're going to create for not, doing the right thing by forcing people to put on masks, forcing or shutting down business. If people don't want to do it, they're just against it, then shut down where they go. It's just that simple. I mean, then you save lives. You save a lot of lives. And stay away from the conspiracy theory and stuff like that. Listen to the doctors. They've been right on every prediction they've made since April, the latter part of April, when they've learned a lot more than they knew going in. They have pretty much predicted everything that's happened. So the good news is, if you can wear your mask, if you can social distance, if you can manage to work your way through this freedom thing, and just do the right thing to stay healthy for everybody, we may be able to get the opportunity to see vaccines work for us, okay? And work for a lot. I mean, the fewer people that have it, the less we have to administer it in come March. That requires us to do what we need to do between now and March. It's just that simple. That's basic math, folks. It's basic math. So help us out. Put your mask on. Stay social distance for a couple more months. Do what it takes to bring this down so we can get these vaccines working for us and get them to more people who need them faster. Okay? Have a great day. This is Vic Vogel. What the Flip podcast. Oh, Tuesday nights, I'm doing a thing for seniors like me, just like how you coping right now. Come jump in and talk with me. Text, message me on this podcast site, this Facebook page, message me and tell me you'd like to join me live. We can sit down and maybe get 4 or 5 of us together and then let people listen to us talk about what's going on with us. We can take a look at some of the comments that come in and respond to them. How are you handling turning older in this world today? Not necessarily just the virus. There's a lot of other things, that you deal with when you get older. Like, you're now a minority. Uh-oh, I wasn't a minority all the way up till I was 65. And then all of a sudden I couldn't get employed, and things were a little harder to do, and there wasn't any accommodation. And now I'm a minority. I kind of understand what it feels like to be treated differently. Wow, what a wake-up call. Okay, we can talk about things like that. So anyway, catch you later. Have a good time. Be safe. Please be safe. And I'll talk to you Monday night. Again, go to the event section on this page and watch, because I may be putting in some stuff for Friday or Saturday and to help facilitate getting through these responses a little quicker. All right. Have a good evening.